Good morning, and Ajay, great to see you. We had an interesting morning talking about TAVR, which of course is a very mature technology. And so transitioning now to mitral, this is a topic I still see as the next frontier. So I'd like to just kind of introduce some concepts and then talk about as a group where we're going from here. Okay, so transcatheter mitral interventions. The mitral valve is much more complex than the aortic valve. There are really 5 components: the annulus, the leaflets, the commissures, the chordae tendineae, and the papillary muscles, as seen in the picture there. And with the 5 components, of course, there are 5 ways that the valve can fail. Initially, we started addressing transcatheter mitral valve repairs with leaflet technology, annuloplasties, ventriculoplasties, and then possibly replacing cords. And at the same time, trying to also find a way to replace the valve. Most of the initial platforms were a transapical access, and we're trying to move towards a less invasive transeptal. I'm going to focus primarily on the transcatheter mitral valve replacement technologies and what we've seen so far, hopefully so that we can start talking about where we're going. So here you see the mitral valve replacement technologies used in a couple of different pathologies, either a valve in mitral annular calcification, a valve in ring, or a valve in valve. And invariably what you see is not great outcomes. And a lot of the initial mortality actually comes within the first 30 days, especially when we're talking about valve and MAC patients. So certainly at this stage, we don't have a great platform to address mitral valve replacements. Mitral valve in ring in the United States is off-label, and really the only on-label use is valve in valve with the SAPIEN valve that's traditionally a transcatheter aortic valve replacement valve. I'll skip that slide, but this is just showing the valve in valve having a much better outcomes. Some of the difficulty with mitral valve replacement with the transcatheter approach is very complex anatomy. As mentioned, there are many features of the mitral valve. It's not just a valve in a tube like the aortic valve. It's integrated into the ventricular wall with the papillary muscles. The entire posterior annulus moves with every beat. It's D-shaped. And so the complex anatomy adds considerably. We do not yet have a dedicated valve system, which adds to our challenge with having a dedicated device that's designed specifically for this. As mentioned in the United States, we're using a TAVR valve in the mitral position. Because of the length of the anterior leaflet of the mitral valve, there's a high risk of LVOT obstruction. And then there's just challenges with deploying the valve. So I'd like to highlight a couple of those features. Again, looking at the anatomy, the components of the valve, the shape of the valve, you can see that this is a much more challenging anatomy to try to position a valve appropriately, as opposed to the aortic valve, which is essentially, as mentioned, a valve in a tube. Here are the various valves that we have seen in the United States. And really, if you look across the entire world, there are many, many more platforms not demonstrated here. But just in the last few years, we've had trials, early feasibility of these valves, and already we're down to this. Early feasibility in Tendyne, going to pivotal, early feasibility in Medtronic, going to pivotal, 3 valves that no longer exist, and then the transcatheter TAVR valve, the SAPIEN 3, being used in a transeptal approach for valve and valve only. So they're very, very limited in terms of what we're able to do, just being able to take a valve and place it into the annulus. Those cases that we saw of the aortic valves this morning demonstrated how easy TAVR has become. We're talking about 3rd-generation devices and conscious sedation, patients awake. For mitral, that's not where we are yet. We have a lot to learn and a lot to overcome before this is going to be mainstream. Some of those limitations come from us not being able to achieve coaxiality. Here's a demonstration. This is a Sapien 3 valve on label in the United States to place in a failed mosaic valve. As you can see, you don't see that stable deployment like what you saw in those TAVR cases this morning. You're trying to land on a very small frame. Fortunately, the surgical valve frame adds a nice platform. But if you're trying to land in a ring or a partial ring or in just mitral annular calcification, you can see where this would be problematic. The Tendyne valve is a transapical approach. We have implanted quite a few here, but the unfortunate part is the apical incision is not as well tolerated. It does require a mini thoracotomy, and the mortality for this valve is approximately 3%. So certainly we have a lot of room for improvement. Here's the biggest concern at our institution. We end up seeing a lot of patients in valve clinic who have long anterior leaflets, and this LVOT obstruction is a real consideration. If you guess wrong and you end up with LVOT obstruction, where there's a dynamic process where the anterior leaflet of the mitral valve essentially closes off the LVOT, the mortality is nearly 70%. And this is a situation where we really have to be addressing these patients, trying to split the leaflet, which you'll see in our case later this morning, as well as trying to identify these cases ahead of time to prevent this complication. Laceration of the anterior leaflet of the mitral valve, or a lampoon, is a technique where you use an electrified wire to split the leaflet to open up that space so that you have flow through the LVOT. And this morning, my team is currently in the process of doing this step so that we are able to deploy a valve for you when we go to our live case. And finally, just showing you two other examples. Here you can see a valve in ring as well as a valve in MAC. You can understand that it's very difficult to come across the septum and achieve coaxiality. You have very little control on the wire in the apex. We've turned to using an apical rail where we're actually externalizing the wire through the chest wall in some cases in order to be able to manipulate the valve. And you can see that we're just not there. Those cases this morning for TAVR really demonstrated how straightforward TAVR has become. And right now, the mitral, this is still a frontier that we have not even started to understand all of the ins and outs of. We have some early devices that will prove beneficial in high-risk patients, but we have a long way to go. And with that, Ajay, I'll turn it back over to you. Thank you for your time.
Thanks so much for that, Kendra. You know, I think it was a great demonstration of specifically not only what is possible, but what some of the challenges are. Let me ask you this. I think that despite the complaints that many people will have going and doing these cases, and they're going to be hard for people to do, is it your sense now, though, if you have a failing surgical prosthesis, that transcatheter technology really is the default strategy? I think many have argued that, but for the general clinicians out there, they might not know what to do with these types of patients. Is that better than a redo? I think we seem to have lost Kendra for a sec, so maybe I'll address that to Azeem, and then Azeem has some other questions. Oh, there she is.
I'm back.
Hey.
I think that it really depends on the patient. There are certainly patients of low risk, young age that are going to tolerate a redo operation, and they're going to do very well. But unfortunately, you know, if you did the initial surgery on a patient who is in their 70s and now they're well into their 80s, maybe have multiple comorbidities, I think that we do have to then be looking for other approaches. As a surgeon, our intent is to always repair first. So that's why you see so many rings. We're held to this standard where we're not going to replace. So I'm going to repair the valve because it's going to give them the longest durability, hopefully, with their own leaflets. And now we have something that's not as easy to fix when it fails. And I think that for many patients, the redo is an appropriate option. But as the patients get older, we're going to have to find other solutions.
Yeah. All right, great. I'm going to hand it over to Azeem, who's going to direct the next part of questioning.
Yeah, sure. Thank you, Ajay. So, I just want to separate for the discussion TMVR, where it's valve in valve, valve in ring, valve in mech versus dedicated devices. So let's stick on the first part again. And Kendra, you showed, this initial data, the data from Yun, where many of us contributed, where if you look at the curves, the survival curves, patients with valve in ring seem to do much worse than patients with valve in valve. Can you and maybe Nicolas make some comments why we see such worse outcomes for valve in ring versus valve in valve?
So, my personal opinion is that the valve in valve adds a much better platform to land the TAVR valve. You have the entire ring, which is circular, as opposed to D-shaped. The entire stent frame, which is circular in a surgical valve, as opposed to a D-shaped ring, which was really not intended to have a circle put in it. So that's one of the limitations. Also, because of the posts, it helps align the valve in the surgical valve annulus. The ring, you don't have that. You still have the ability to cant. One final piece is that most of the time when I'm implanting a surgical valve, I split the anterior leaflet and move the chordae to the sides. So I've already opened up the LVOT ahead of time. So you're not going to find as many patients who are going to be at risk of LVOT obstruction for the valve in valve, as opposed to the valve in ring, where I absolutely do not modify the anterior leaflet.
Right. I think those are important
so
considerations.
Azeem and Kendra.
Nick?
Yeah, I think I'd like to add to that to me that was a little bit surprising to see that patients with ring would do worse than patients with a failing bioprosthesis in the mitral setting. But I think it can be explained by what Kendra was mentioning, that they already are splitting the leaflets when they implant a bioprosthesis, a surgical bioprosthesis. That said, though, I think we have to take into account that we're still talking about an early experience in this mitral space in terms of mitral valve implants. And I do believe that we have gained a lot of granularity by using specialized 3D planning tools now. And I would assume and I would think that we are getting better in predicting the results before we enter the case. So my gut feeling tells me that in the future, the difference between a valve in ring and a valve in valve might become smaller.
Right. Maybe, I think we should, move the discussion a little bit to dedicated TMVR devices. And there's no one better to ask than Lars. Lars performed the first ever transeptal implantation of a dedicated device, Lars. That was cardiac Q, 2014 or earlier. Is that correct?
2012.
2012.
2012.
Wow. Okay. So
actually June 12th, so on Friday it's a
So the cardiac Q doesn't exist though anymore. As we heard from Kendra, it's been iterated in a different valve, and that just kind of stimulates the discussion about how challenging TMVR has been. So, it's been 8 years since you did that procedure, and now we have the first device that's available in Europe commercially, Tendyne, which is transapical. Maybe if you could just highlight particularly for our audience, many of whom may not be interventional cardiologists, why it's taken so long and what some of the challenges have been.
I think there's multiple answers to this question. First of all, many of the patients who's coming forward with severe mitral regurgitation have functional mitral regurgitation, so they have an LV disease. And the simple way to approach the mitral valve is by a transapical approach where you work in a straight line. It's easier for the engineer to design a system like this, but it's quite large system. So we have seen system between 30 and 14 French. So it's a big hole in the left ventricle. So that's one in a functional mitral regurgitation. So we've been better to take the patient out of this if they have too much impairment of the left ventricle. Left ventricular outflow tract obstruction has also been an issue in some of these patients, and bleeding issues has been an issue. So I think what we have seen down the line is that we have system where we can close the apex very safely. Tendyne have this feature with the small button on on the string at the apex, and also you tend to can direct the direction of the valve, so you avoid left ventricular outflow tract obstruction. So again, even though we have it CE-marked today, remember it's still quite selected patient who is going into this therapy for the time being.
Ajay?
Yeah, no, I think that, the other aspect that I think people, don't really recognize, and it has to do with the point that Kendra made earlier, was really that not only is the anatomy more challenging, there's nothing to anchor the valve, but also the ventricular component of things really impacts how the valve can be put in. And I'm sure that that's something Nick is going to get to in his talk later when we talk a little bit about functional and other percutaneous repair strategies. Because that's not something that's an easy problem to solve and not an easy one to iterate, and why every device has to do it a little bit differently. Maybe one last quick comment, either Nick or Holger. Is this, before it goes prime time, transseptal the only way to go with this, or do you still see a use for transapical?
So from an interventional perspective, for sure, we always looking for the transseptal approach. Maybe that's important also to consider. But maybe just one comment on why these specific or dedicated mitral valve devices have not been so successful so far, because all the intervention techniques what we currently have, like edge-to-edge repair, they work so nice, and so maybe it's also one option.
Okay.
We
have an audio problem, unfortunately. Maybe Nick, you want to make a quick comment? Sorry, Holger, we just can't hear you properly, so I just want to make sure we have a quick answer before we go to the next talk. So
the question was again, what was your question again? Sorry, I forgot.
Very simply, before it goes prime time, does it have to be transseptal?
Yes, I'm convinced that these hearts that face MR and then would be exposed to an apical approach, they are getting in trouble. And I think if we can avoid the damage and the injury to the apex by going transseptal, it will benefit our patients. To me, there's no question.
Great, thanks, Ajay. Once again, what a pleasure to be doing this session and to be talking about one of my favorite topics, which is transcatheter tricuspid interventions, which I really do think is an area of amazing growth over the last few years. So I do want to, set the stage for why we need transcatheter interventions and not just really dive into a series of devices. And remind our audience that for many years, this valve has been called actually the forgotten valve, because for many years as cardiologists and physicians in internal medicine, we thought that all that was needed was diuretic therapy for tricuspid regurgitation, or if the TR was associated with left-sided disease, treating the left-sided disease and the TR would go away. We've subsequently learned, and I'm going to show you some of the data, that actually that's not true. And it's not actually surprising when you see in the literature that there are numerous articles where the tricuspid valve has been called the forgotten valve. Fortunately, we can forget about this nomenclature because it's really become the area of interest and study now with a number of studies. So let's talk about who these patients are to start with and how prevalent tricuspid regurgitation is. So on the left, you see some numbers from the United States, and it's estimated that there are at least 1.6 million patients with TR in the United States. The number, it's difficult to figure out exactly where this number comes from, particularly the 250,000 new cases every year. But one of the things that we really do know is that the number of surgeries for isolated tricuspid regurgitation annually is actually minimal. Most surgery that's done is in combination with mitral or aortic valve surgery, but isolated tricuspid valve surgery, they're probably less than 8,000 annually in the United States. If you look at the study on the right, it gives you probably a better understanding of the prevalence of TR. This is a study done in Oxford in people who are over 65. It's an echo study, so these were not was done in the community and not a hospital-based study, and just gives you some of the prevalence of heart valve disease. So you see aortic stenosis 1.9%. We know mitral regurgitation is more prevalent, 3.5%. But look at TR, it's actually more prevalent than aortic valve disease, yet we give it a lot less attention than aortic valve disease. So if we look at what causes TR, and you look at this bar chart on the right, you see that probably 95% of TR is caused by secondary causes or is functional TR. Less than 5% is probably primary TR or congenital TR. So most of the TR we see is caused by either heart, left-sided heart valve disease or heart disease, or pulmonary disease or pulmonary hypertension or LV dysfunction, with left-sided valvular disease accounting for at least half of these cases. So why are we talking about TR? Why is it important to you as a physician or to you as a cardiologist? Well, I've chosen just 3 studies here, but I could probably show you, 20 different studies now in every single population that's been studied, showing that TR has an impact on long-term survival and prognosis. The most quoted study is the study by Nath as early as 2004, showing that both moderate and severe TR shorten survival, and this is independent of RV function, size, pulmonary hypertension, and LV ejection fraction. Similarly, there's studies looking at heart failure populations, looking at patients with mitral disease, looking at patients with aortic valve disease or post-TAVR, or looking at patients even with LVADs. Any population you study, and once you've corrected for other baseline factors, TR is shown to be an independent predictor of mortality. And so it's something we need to think about. Besides the fact that it makes patients feel bad when they have symptoms, it actually impacts their prognosis in a negative way. We've also learned that the cause of TR impacts the prognosis in different ways too. So the worst mechanism for TR is probably LV dysfunction valvular that results in the highest mortality, the highest rate of heart failure hospitalization, atrial fibrillation. The congenital ones and the isolated TRs have a slightly better prognosis. So, as you know, when diuretics don't work, what do? We send patients to surgery. Surgery really has been the gold standard for tricuspid regurgitation. There are a number of repair techniques that can be used. The most common technique used right now is annuloplasty, but the valve's often replaced as well, and there is a geographic difference about whether the valve is repaired or replaced. So let's look at some data, because historically we've always said that surgery for TR is associated with a terrible prognosis. So here are 2 studies from the United States looking at a 10-year experience with tricuspid valve surgery and the outcomes. And what you see is that actually isolated tricuspid valve surgery is not performed as common. And here, if you look at the red line, is isolated versus in combination with other surgery. And here on the right is replacement, the red line, versus when it's performed in combination with other surgeries. So isolated tricuspid valve surgery is not performed commonly. In the United States, certainly, repair only accounts for about 40% of the cases, whereas replacement accounts for 60% of the cases, which was surprising to me when I first saw this, because we all know and believe that repairing a valve is better than replacing it. But often these patients are referred very late. What is concerning is the in-hospital mortality rates, if you look here at the bottom. So over a 10-year period, in-hospital mortality rates have not changed. They've been between 8 to 10% for repair and replacement. That's pretty high if you compare it to other elective surgery, valvular surgery that's performed. So realizing that there have not been many maybe just before that, why are these patients at high risk? Because I think a lot of it is we are referring patients too late to our surgeons. That by the time we decide that diuretics are not working and we refer patients to our surgeons, these patients are elderly, they have multiple comorbidities, they have liver dysfunction, renal dysfunction, and they're pretty advanced with right-sided heart failure. So we really, if we do want to improve the outcomes, these outcomes are not related to the fact that surgeons are doing a bad job, but it's related to the fact that these patients are referred at a very advanced stage. So, it's not been surprising when you look at, there's a lot of patients with TR, it impacts prognosis, but yet the gold standard, which is surgery, is not performed often because these patients are often referred late with multiple comorbidities. There's been really a flurry of new devices that have been developed to try and perform tricuspid valve repair or replacement in a less invasive way using a transcatheter technique. So there are multiple devices. We won't have time to go over all of them today. We can maybe discuss some of them in this discussion. But basically, most techniques try and reproduce what surgeons have done surgically, either by trying to do suture annuloplasty, do a ring, or by replacing the valve. Probably the most common device that's been used with more than 2,000 cases performed worldwide is tricuspid clipping, initially using using the mitral device, but recently a dedicated tricuspid delivery system and tricuspid device has become available, and we'll be seeing that in the live case today. With this device, we end up clipping, two of the commissures, the anteroseptal and the posteroseptal commissure. And if the procedure is done well, you do see that the outcomes are very promising. I'll just go forward, excuse me. So here's just showing you some outcomes. We are able to reduce TR with these devices, and we are able to make patients feel significantly better. There is a large study, the TriLuminate study, which has really shown the safety and the efficacy of this device, and it's a study that's resulted in CE mark approval of the TriClip device. There are other techniques that are available. An area that's growing rapidly is tricuspid valve replacement. There are now at least 6 valves that are under study for tricuspid valve replacement. These can be implanted either transatrially, via the transjugular route, or via the transfemoral route. I would just maybe finish with 2 or 3 slides. The one, there are no randomized data comparing tricuspid valve intervention versus medical therapy, but in this retrospective propensity score analysis that we performed, we do show that there is signs that it decreases mortality and decreases survival free from heart failure. But really, my appeal to those of you that are listening is that we need to start acting on tricuspid regurgitation earlier. Most of the patients that I'm being referred right now are patients in this very advanced stages with RV dysfunction, RV dilatation, significant tricuspid annular remodeling. And really what we need to do is identify patients early, identify patients at this point where if we intervene, they can recover RV function. Unfortunately, many patients we are being referred now are being referred when they've pretty much advanced and end stage, and where even a transcatheter intervention may not be impactful. So I guess my final appeal to you is to really highlight the importance of TR and that we need to start acting earlier. Thank you.
Thanks so much, Azeem. That was a fantastic overview. And I think just to pick up on your last point that you were making regarding, intervention, one of the challenges is that because the surgical outcomes aren't great, many people don't get referred at all. And so it's sort of changing that paradigm of referring only the sickest people to then going more upstream. So maybe a question from probably for Holger. Now we have your sound back. Who is the type of patient you want to refer for tricuspid percutaneous intervention? Is it somebody who has clear primary TR, or is it secondary? Some patients. What kind of workup do you do, and how do you educate this?
Yeah, so we treat both kind of patients. So we treat patients with primary TR as well as the majority of patients with secondary TR. And the patient we showed now today in our live case will be a patient with secondary TR. very important is the echocardiographic setup before. So you will have to check really if the patient is suitable for interventional approach. And this is very, very important. So you have to look for the gap. You will also have to, the coaptation gap plays a big role. Then you will also have to check the jet, if it is a central jet or is it more an eccentric jet. So these are predictors which we have learned when we started with this technique, which help us to define if this patient will be a suitable candidate where we will have a good final result afterwards. So this is very important in advance.
And Kendra, do you feel that for these patients that you would potentially even, if they're operative, operate earlier too? Can this entire paradigm be shifted a little bit more upstream, or are we really waiting to the end for these folks?
Yeah, I think that Azeem really hit on something that's really important, and that is if you hand me a patient that's high risk and already end stage and expect me to fix all of what's wrong with them, including fix their liver, you're not going to end up with a good result. And so if we continue to do percutaneous therapies on end-stage patients, you are going to continue to get the same type of bad results as you get with surgery. So I couldn't agree more that we need to be intervening earlier. And I know that's a hard concept because there isn't a surgical precedent. You said it yourself, the surgical results are bad. But I think that's because we're waiting for the patients to get so bad we can't help them.
Lars, what kind of results are you looking for in terms of what you can reduce the TR to, and what do you tell patients? You're going to make them feel better, they're going to live longer, you're going to keep them out of the hospital. What do you tell the patients and their families?
Yeah, we don't have any hard endpoints, but I think it's going to be a quality of life, less symptoms. We're discussing on the edge-to-edge repair on the mitral side that people are not. Can you hear me?
Yep.
Yeah. I mean, the edge-to-edge repair on the mitral side that, you still have some mild to moderate regurgitation after the transcatheter approach with the mitral clip system. On the tricuspid valve, patients come with tremendous tricuspid regurgitation. And some of these patients, you leave them with a severe tricuspid regurgitation. It's improvement, but it's far from ideal. So either we need to treat these patients early on, or we need other devices to treat them.
And then finally, Nicolas, because I know you're going to be speaking a little bit about functional, just tell me really briefly, for these types of patients, is the echocardiography tricuspid specific, or do you have to, you just use mitral type of measurements and outcomes? Do you have to come up with individual specific criteria for the tricuspid valve?
I think there are some individual criteria for the tricuspid, and I think the importance of the right ventricle cannot be underestimated. And also, make no mistake, I mean, the tricuspid valve has 3 leaflets, and it's again a totally different environment than the mitral space. So I'm sure that eventually we will not be extrapolating what we know from the mitral valve to the tricuspid. The tricuspid valve is a different animal, so it will have its own particular set of measurements and aspects that we need to evaluate before we can proceed to one technology over the other. And I think it's also important that it's already fair to say that there will not be one technology that will fit all tricuspid regurgitation patients. So we will eventually also there evolve to a more patient-tailored technology selection.
Azeem, did you want to make a comment? And what's your experience taught you in this regard?
I had a question for, I'm an ex-European, so for my European colleagues. We now have 3 devices approved in Europe for TR. Okay, there's the Cardioband, there's the TriClip, and now even Pascal. We have none approved in the US, and it'll still be probably a couple of years before we have anything approved in the US. Do you believe we have enough data right now to support having all these devices, or do you think we still need randomized data to really show that these devices are better than medical therapy? Holger?
Yeah, so as an evidence-based physician, I'm always believing in randomized trials, and that's the reason why you have nicely shown these propensity match data, but this is only the first step. I think the next step has to be that we go for a large-scale randomized trial like COAPT-HF, and that we really can be able to show that there's not only symptomatic improvement, but also prognostic improvement, and I think this is a prerequisite which we need now. This is very, very important. We need a randomized trial. This must be the next step.
Nick, what are you using in Holland? What do you have available, and what are you using in your practice?
Yeah, so we are getting our hands on the TriClip and on Pascal. There has been Cardioband is available, but I don't think it has been used that often in the Netherlands. I do deviate a little bit. I have a different opinion in terms of do we really need a randomized trials for reimbursement purposes? I think we need a randomized trials to solidify our guidelines, but for reimbursement purposes, I do see a lot of value in a large prospective registries. Basically also what we did with the MitraClip. So a lot of the insights have come from registry data before we had the randomized trials. So thank you, Ajay. So I will be providing some recent insights on COAPT and MITRA-FR. Again, a little bit, some of my conflicts, or all my conflicts, basically. So what do we know about the unmet clinical need in heart failure? Well, we will learn from our heart failure docs that patients with heart failure have a high likelihood of also developing functional mitral regurgitation. And it is not a trivial thing, because they may have up to 50% rehospitalization rate after they have been hospitalized. And we know that the presence of FMR is a predictor for rehospitalization and mortality. Also, we know that CRT in these patients can be quite effective, but in 1 in 3 of those patients, CRT will be not effective. And a quarter of all the patients who receive a CRT device will have at least moderate functional MR. And then, of course, we all know that surgery for functional MR, which is different from surgery for degenerative MR, has not a proven benefit. So basically, the cardiology space and the cardiothoracic world as well was rocked in 2018 with the sequential publications of 2 randomized trials involving the MitraClip in patients with functional mitral regurgitation. And I think the fact that both trials had somewhat opposite results created a lot of confusion. On one hand, you had the MITRA-FR trial, which was a trial run in France of 307 patients. And then on the other hand, you had the larger COAPT trial that was done in the United States and included 614 patients. Well, the main results are shown in this slide. On the left-hand side, you see that the MITRA-FR study reported no effect of the use of the MitraClip in terms of their endpoint of the probability of freedom from a composite of hospitalizations and mortality, whereas COAPT on the right-hand side had a clear benefit in terms of its primary endpoint of number of hospitalizations in favor of the patients who received a MitraClip. And that was a little bit difficult to reconcile. But if you look at the COAPT of the COAPT results, it was also quite striking that the effect of the MitraClip was quite apparent early on if you just look at the hospitalization. So it was really within 3 months you saw that the curves were quite diverging significantly. And if you then look only at mortality on the right-hand side, after 1 year, the curves started to diverge. So I think the results of COAPT are quite compelling, but also are in line with what we were thinking about the impact of functional MR. And the reason why MITRA-FR was then not a positive trial, we'll get to that a little bit later in my talk. So an interesting insight came last year from this trial, and it was given by Greg Stone at the TCT meeting, where he looked at what happened to the patients in COAPT who were in the control arm after 2 years when the study endpoint was reached. Well, after 2 years, there was a significant crossover of patients in the control arm who then went for a MitraClip. They identified eventually 138 patients, where 85 did not have a crossover and 53 did get a MitraClip after at the end of the study. And then it becomes interesting, because if you look at the endpoints of those patients, and if you start to follow them up, the moment they received the MitraClip, you could see that they would start to behave like the MitraClip arm from the trial. And that is quite an interesting observation. And this is shown in this slide, where you see in red the control arm of the MitraClip, in green the MitraClip arm from COAPT, and then in yellow, those are the patients who crossed over after 2 years with then a landmark analysis when they received the MitraClip. And then you see that they start to behave like the patients who received the MitraClip within the trial. So this was quite an interesting and, to me, a compelling observation, but it was a limited number of patients. So let's go and take a step back now. Why were the MITRA-FR findings different from the COAPT? Well, probably because the patients who were enrolled in MITRA-FR were different from the patients in COAPT. And they were different because the LV dilation was much more significant, much more pronounced in the MITRA-FR. As a matter of fact, it was 25% larger, the mean LV dimensions, as compared to the LV dimensions in COAPT. On the other hand, the severity, the MR severity, was more pronounced in the COAPT trial. So basically, you had a different phenotype of heart failure patient in MITRA-FR versus COAPT. And then some additional perspectives from recent publications. This is a publication from COAPT that was published in JACC earlier this year, where they looked at a change in quality of life. In blue are the patients who were in the control arm. In red are the patients who were in the MitraClip arm. And it's clear that you see that there were more patients in red who were improving, where the KCCQ score was improving as compared to the control arm. As a matter of fact, on average in the control arm, the quality of life was deteriorating, whereas the quality of life was improving in the patients who received the clip. And this is also demonstrated in this slide. In gray, the gray line demonstrates the patients who received the clip in COAPT, whereas the yellow line showed the control arm. So those patients did not get a clip. Well, you see that the patients in the control arm in COAPT, they were deteriorating. Their quality of life was going down. In MITRA-FR, there was a different observation. Both the treated patients who received the MitraClip, but also the control arm, were both improving. And that is a little bit strange, because if you are optimally medically treated, so basically the heart failure specialist did what he or she could do for that patient, then the only what's going to happen with that patient is that, you know, the patient will remain stable up to a certain point, and then they will start deteriorating. So they will no longer improve once they are on stable heart failure medical regimes. And this is where I think a major difference comes into play. In the control arm of MITRA-FR, the patients were improving because their medical therapy was being further optimized. And this is different from COAPT, where the patients were only eligible for the study the moment that they were proven to be maximally treated. So there was no more extension of their treatments in terms of medical treatment in the control arm. So basically, MITRA-FR control arm does unexpectedly and counterintuitively improved. There was also something going on with the patients who were in the MitraClip arm in MITRA-FR, because there was a failure rate of almost 10%, which is quite high and not reflecting our practice. And finally, there is a lot of missing data from that study. So the COAPT trial probably is a better quality study and will probably also give us more and better insights to understand what a clip can do for patients with FMR. That said, there were also some strange findings within COAPT, at least in my perspective, and this is an echo sub-analysis, a predefined echo sub-analysis from that COAPT trial, where it was clear that if you look at the LV dimensions, and that, of course, tells you something about remodeling. It was not improving. You did not see reverse remodeling, not in the control arm, but also not in the patients who received a MitraClip. So that tells you and explains also why the eventual endpoints were quite high also in the MitraClip arm. And it basically also refers to what Azeem told us earlier, that when you send these patients too late, when they are at the end of their lifespan as a heart failure patient, it becomes very difficult to affect their clinical outcome in terms of survival. Another interesting factor that came across from the COAPT trial was that there were no echo-determined parameters that were predictive of a positive outcome. So basically, if you looked at LV dimensions, or you looked at MR severity, or you looked at pulmonary hypertension or whatever, they could not find a predictor for MitraClip responsiveness. And this is a little bit strange to me, but it also might tell me that these patients, they were only enrolled at the relative end of their life cycle with heart failure. So I think, and this is maybe the elephant in the room, what are the challenges in heart failure drug therapy and drug delivery? And this is to the heart failure community. I just want to highlight the CHAMP-HF trial, which was an observation in the United States, where they looked at heart failure patients. And you see on the left-hand side the presence of any heart failure therapy at baseline versus 1 year. On the right-hand side was the target dose. How many of those patients were treated with the target dose of these respective medical therapies? Well, on the left-hand side, you see that when they entered the registry, 2/3 were on ACE inhibitors, 80% on beta-blocking agents, 30% on an MRA, and only 13% on an ARNI. But 1 year after, 1 year later, despite the fact that the heart failure specialists and the treating physicians were informed about the fact that potentially their patients were undertreated in terms of medical therapy, nothing had changed. And the same thing if you look at the dose of the medical therapies. The number of patients who were on the randomized trial study recommended target dose was minimal. Only 10% of the patients who were taking ACE inhibitors or ARBs were on the target dose. But that didn't change at 1 year later. So that gives us a lot of reasons to believe that it is in reality very difficult to keep patients on heart failure drug therapy and also to maintain the target doses as recommended in heart failure trials. So with that, I would like to summarize that, yes, there is an unmet need for FMR therapy in heart failure, and I believe that MitraClip does improve FMR. It did improve FMR in MITRA-FR, it did improve FMR in COAPT, and the patients were feeling better. There was only no difference in MITRA-FR between the control arm and the clip, whereas there was a difference in the COAPT. And there is maybe a sweet spot of an intermediate heart failure phenotype that would in particular respond to MitraClip therapy for FMR. And this patient might be defined, or this intermediate phenotype might be defined by an ejection fraction that is not the worst of the worst. So basically an ejection fraction over 20%, an MR with an effective regurgitative orifice area between 0.2 and 0.4. The patient should not have end-stage heart failure symptoms. And at this point in time, unfortunately, there is no clear echo parameter to help select. However, common sense tells me that patients with fixed severe pulmonary hypertension or extremely dilated ventricles will also be non-responders to MitraClip. With that, I'll give the floor back to you, Ajay and Azeem.
Thank you, Nick. That was a great presentation overview of two studies that, gave very different results. And I think you summarized some of the important differences of the two studies. Particularly, just to summarize for our colleagues, I think we saw that in COAPT patients had to be really an optimal medical therapy. And then once they were on optimal medical therapy, had to have very severe MR with smaller ventricles. Whereas the MITRA-FR group, those patients were more advanced, maybe more dilated ventricles. Their MR was not always as severe. And and maybe the outcomes were not as good, and there was a lot of changes to medical therapy along the way. What surprised me was how these two studies have been interpreted in different ways by the heart failure population in Europe versus the US, right? So in my center, for example, our heart failure group has really embraced the COAPT data. It's increased our referrals for mitral clip probably by 100% compared to what it was before the COAPT data came out. I wanted to hear from, from Holger and from Lars. In Europe, I'm told that it hasn't had as such a great impact on the number of patients being referred for mitral clip. Is that true? And what do you think some of the challenges are?
So
Lars?
will you start or?
Yeah, I can start. I mean, so if you look at those two trials and you say that the COAPT patient will certainly benefit from clipping, these patients are actually quite hard to find. And you saw how long it actually took to enroll the patient in the COAPT trial. So despite it was positive, if you at the same time say that the patient who are a mitral FR patient should not be referred for clipping, I think that's at least one of the limitation in Denmark, why we see very fewer patients with mitral FR patient referred as in the past, and it doesn't really balance with a COAPT patient. And another very important thing, I think it's these patients are followed by the heart failure community, and they tend to try to do everything else before they referred for mitral clip, all the medical treatment, CRT, and so on. So maybe it will be more interesting to try to see, should edge-to-edge repair come earlier in the treatment algorithm? Should it really be the last stage and the patient will come at end-stage heart failure for intervention?
Yeah, I think that's a great point. Certainly in our institution, sorry, Ajay, our heart failure specialists are seeing it as a way to delay time to LVAD or transplantation. So if they could get the patient, a mitral clip and the patient's symptoms improve, that would delay then that patient going to transplantation or to LVAD. So they're not waiting to get to that end stage. And I think that's really an important point for the colleagues. Ajay?
Yeah, I think that, and Nicolas actually stated the differences really, really well. But one point that I think should be made, especially because this is an online internet meeting, is that there's definitely been a lot of bantering thrown out there that because one trial was industry sponsored and the other one was independent, that therefore cheapens the value of the industry sponsored trial, despite the fact that it's almost twice the size, and despite the fact of all the other limitations of the other study that Nicolas pointed out. And so I think my own view on this is that's, one aspect of what's going on. But in a sense, it kind of almost proves the point that if you sort of don't carefully select the patients and don't do it in a really, really reproducible way, then it's hard for a procedure to show benefit. On the other hand, if you pick the right patients after they've been optimally managed, and then you do the procedure with high reproducibility and good outcomes, because as we know, with mitral valve intervention especially, volume and outcomes makes a difference. Just the achievement of less than 2+ MR, you need to do a lot of cases to be able to do that, shows you that there's value to each. And I think that there's this prevailing theme on the internet these days to just devalue anything that's industry associated. And my own opinion is that ought to be corrected. Any thoughts? Maybe Holger, you've done a lot of randomized trials that are independent as well. Am I being unfair here, or is it right? What do you think?
No, I fully agree with you. So COAPT-HF has much better control of the medication, and I think this is the most important benefit of this trial, and it, for sure it included much more patients. So I would trust much more these data from COAPT-HF in comparison to mitral FR. And with respect why, or maybe in some countries in Europe, the adoption has not been as high as what has been seen by Azeem, Latib. So in Germany, so it's different. So we already have adopted to use the mitral clip procedure in patients with FMR. And so we had an increase after the publication of mitral FR and also after COAPT-HF, but the increase was not as big as before because we already have adopted to use the mitral clip procedure or the edge-to-edge procedure in many patients before. And based on all the registries which we have seen an improvement in symptoms, and also based on propensity matched comparisons, we also have seen this decrease in mortality, and that's the reason why we are still using it, and it has been increased, but maybe not as much as in some other countries where it is more conservative.
Yeah, you know, one of the factors we haven't spoken about, Nick, and I'd like your comment, why mitral clip will continue to be a really important device. And you mentioned it, but maybe you need to highlight it again, is the safety of this device.
Yeah, I think that is a very important comment. Mitral clip is very safe. It is, of course, a procedure under general anesthesia, but a part of that, with the current techniques of transseptal puncturing, and then the way that you can really control the grasping, it is a no-brainer that this is a safe procedure and definitely is reproducible in many centers.
Well, thanks so much. I think we're going to go ahead and wrap up and go right to the live cases, which will hopefully illustrate exactly the point you just made. Thanks so much. Oh, I'm being told we have to do the poll result first, and so sorry, I'm remiss in that regard. So if we could put up the results of the poll for the reference standard to treat severe functional mitral regurgitation, still surgery with just over 400 votes. So let's see how these procedures go, and we don't have a post-assessment, but we'll see if anybody's mind has changed. Yes.